let's shift gears a little bit now and go into the metastatic setting. And I'm going to ask Ed to kind of give me a start off on how you assess a patient. Somebody comes in, presents with, let's make it presents with metastatic disease. How do you decide what to do with that patient in the absence of a clinical trial?
So in the absence of a clinical trial, there are, in my opinion, two standard cares, the FOLFIRINOX and gem/nab-paclitaxel. And we do not have, at this point, head-to-head data to compare the two. This is a different setting than we've been talking about, where in adjuvant setting where you have nothing to follow. This setting, we at least have something to follow. And for me, fundamentally, it comes down to patients' fitness, but also their goals of care. I think we have to recognize the really difficult position these patients are in with metastatic disease, oftentimes with not great performance status, needing something for not just treatment, but for palliation. This really is that we can't lose sight of that aspect of it. And for me, it's very important what my patients, not their preference specifically, but their goals of the care.
In colon cancer, we're seeing this shift back from just making sure everybody gets all the treatment to sort of an induction concept where it's justified to give more intensive care therapy up front, and then maybe back off to a maintenance kind of approach. Paul, do you see that kind of happening here as we think about frontline regimens?
So I do, but I think there's a challenge in pancreatic cancer that is not as common in colon cancer, which is that often patients, even young, previously healthy patients, come in very symptomatic. Yeah. They've lost a lot of weight, they're in pain, they're miserable. Yeah. And it's difficult to go in on day one and blast them with everything we have. So there are times where that's not the case, but sometimes we have to escalate the chemo, we have to ease them into it. But I do think that we see that first 2 to 4 months of chemo, really we want to give as much as we can.
It's sort of like you can't afford to be wrong in a lot of these patients. It's the exception that you can get to progression of disease at 2 months or 4 months and switch. Are you thinking lines of therapy right from the beginning, or are you thinking let's just get off the ledge first and then see where we are, Allison?
I do think of lines of therapy. I also try to work with our precision medicine program to make organoids and do drug testing so that we can try to, sprinkle this on, which is going to work the best. I mean, it really only works when you need it right then, because as you treat it, the tumors change and mutate. But I try really to think about what I'm going to do next early on, and I do push through. And even though they're so symptomatic, it's the disease, and as soon as they respond, they feel so much better. So I pray that I'm going to be able to get them through it, and I'm like, what am I doing? I'm giving them a really hard regimen, but I just try to get them through it the best I can so that they have a chance of responding.
Yeah, I hate this decision because I don't really know what to do, and at least in my clinical experience, it seems like some patients will respond to 5-FU-based therapy and some will respond to gem-based therapy. It's very hard to predict. And also tolerance. Some will find one very easy and the other difficult, vice versa. Right. Are we ever going to get a biomarker that'll help me say, I'm going to give this patient FU-based therapy or this one gem-based therapy?
I think people have tried. It's been, again, it's unclear, which one. I think the best biomarker we could use right now is the germline testing for BRCA, and if they're BRCA positive, platinum steers you towards platinum. So I think that's the best kind of biomarker that we have till now versus anything else that we've tried till now.